All right, imagine you're an emergency medical responder staring down severe trauma. There is zero room for hesitation. Welcome to this explainer, where we're diving into a rigorous, step-by-step analysis of life-saving gunshot first aid protocols pulled directly from clinical training materials. We're going to break down the exact sequence of actions you need to stabilize a patient when every single second counts. In high-stress environments, cognitive overload is absolutely your worst enemy. So here's our 6-step mental checklist. Scene safety and evacuation, hemorrhage control and tourniquets, IV access and fluid resuscitation, vitals, oxygen and shock, clinical pain management, and finally, elevation and blood transfusions. Let's dive right in. To really ground ourselves in reality here, we've got to understand the environment. Our source material focuses specifically on combat zones. A gunshot wound, or GSW, well, it isn't just a simple scrape. It's a massive, traumatic disruption to the body's vascular and organ systems. It demands an immediate, aggressive, and highly structured clinical response.
Starting with Phase 1, scene safety and evacuation.
Now, I know this sounds incredibly basic, but it's the absolute foundation of all trauma medicine. Before any bandages come out, before you even think about prepping IV lines, the rule is crystal clear. Secure the patient and get them out of the line of fire. You simply cannot treat a patient if you're standing in a dangerous combat zone, right? And you certainly can't save a life if you end up becoming a casualty yourself. So, scene safety, totally non-negotiable.
Moving on to Phase 2, hemorrhage control and tourniquets.
All right, once you're out of immediate danger, we target the #1 threat to life, catastrophic bleeding. We've got to stop it fast. Notice the specific clinical terminology here. Step 1 calls for a hemostatic dressing. Think about the word. Hemo means blood and static means stop. This isn't your everyday gauze, it's literally designed to induce rapid clotting. Next up, you secure that dressing with a really tight compression or pressure bandage. And finally, for an extremity wound, apply a tourniquet. The source is super emphatic about this point. Tie it completely tight. Do not leave it loose. A loose tourniquet is basically an ineffective tourniquet.
Which brings us to Phase 3,
IV access and fluid resuscitation.
16. Honestly, I want you to sear this number into your memory. When dealing with massive trauma, this number is basically your lifeline. So what's 16? It refers to the needle size. The protocol dictates using a 16-gauge large-bore IV cannula for massive gunshot wounds. You only, and I mean literally only, drop down to an 18-gauge if a 16 is absolutely nowhere to be found. Why is this so critical? Because a larger bore means you can push life-saving fluids back into the patient's circulatory system so much faster. To really grasp why we need that massive IV line, let's look at the fluid replacement ratio. Notice how the fluid you give has to drastically overcompensate for the blood volume lost. Think about it like this. If the patient has lost roughly 2 liters of blood on the battlefield, you've got to pump in 3 liters of IV fluid. You are aggressively working to keep that vascular system from just totally collapsing. Next up, Phase 4, vitals, oxygen, and shock. Okay, so you've stopped the bleeding and you're slamming fluids. Now let's methodically walk through this checklist to monitor the patient's physiological response. First, track SpO2. If oxygen saturation drops, you start oxygen immediately. Next, monitor blood pressure like a hawk. Significant blood loss is inevitably going to lead to hypotension or dangerously low blood pressure. At the exact same time, check the pulse. You're looking for tachycardia, that rapid heart rate, because the heart is working overtime trying to pump whatever blood is left. And of course, keep a constant eye on the respiration rate. Here's the crucial takeaway from all this. Those vital signs are the alarm bells telling you if the patient is crashing. All that blood loss creates a massive risk of them slipping into hypovolemic shock. So we maximize IV fluid administration to actively fight that off. Those fluids are literally the physical pressure keeping the body's engine running. All right, Phase 5, clinical pain management. Now, I really need you to pay close attention here, because we're going to do a little vital clinical math. Here is your baseline measurement straight from the protocol. A standard injection ampule of morphine has 15 milligrams of medication crammed into just 1 milliliter of fluid. Do not inject this directly as is. We've got to dilute it for safe, controlled administration. Let's demystify this math step by step. First, you draw that 1 milliliter of morphine into your syringe. Second, add 4 milliliters of normal saline. Okay, so now you have a total fluid volume of 5 milliliters, but it still contains that original 15 milligrams of morphine. This means every 1 milliliter of your new mixture has exactly 3 milligrams of morphine. Step 3, administer just 1 milliliter, which is 3 milligrams, of this mixture through the IV. Finally, reevaluate the patient's pain and repeat that 1 milliliter dose every 15 minutes if needed. You've really got to memorize this exact dilution formula and that 15-minute interval.
Finally, phase 6, elevation and blood transfusions. We're bridging the gap here between immediate field care and long-term recovery. If the gunshot wound is on an extremity, like an arm or a leg, you need to elevate it. The source recommends 12 to 18 inches. And there's a simple, undeniable physiological reason for this: gravity. Elevating the limb redirects critical blood supply away from the extremities and pushes it straight to the brain, where it's obviously needed most. Now, eventually, this patient is going to need real blood to replace what they lost, 250 to 300 ml. That right there is the volume of a single standard unit of blood you'd get from a blood bank.
But here's why that specific volume is a massive problem in an emergency. Let's contrast these facts. A patient can lose 2 liters of blood in mere minutes, right? But transfusing a unit of blood takes 3 to 4 hours, because a tiny 250 to 300 milliliter unit doesn't even come close to covering a 2-liter loss. And because the transfusion process is so incredibly slow, you can't just stand around waiting for blood. Running continuous maximum IV fluids alongside any blood transfusion is absolutely mandatory to keep them alive. Which brings us to our final takeaway. We've walked through securing the scene, aggressive hemorrhage control, slamming fluids through a 16-gauge IV, monitoring shock, calculating morphine, and the harsh reality of slow blood transfusions. This sequence, it isn't just some textbook list. It's a vital, structured protocol designed to save lives in the most chaotic environments imaginable. So, the ultimate question is, when seconds count and a life is literally on the line, are you ready to execute this protocol? Thanks for joining me for this explainer. Keep learning, stay focused, and I'll catch you next time.